like to clearly thank the organizers to get to participate in this really great symposium. Peter, thank you for the plug in the slide, and I don't think I'll be here in 50 years for the 100th celebration, even if you never know. My mom's 98 and still living independently, so there's a potential, but wouldn't count on it. I could mess things up. So what I'd like to do is give some idea of what are the opportunities for long-term lung growth following premature birth. Let's see. And first, I'd like to just kind of focus on making sure we separate out, we frequently use the word lung and lung function and lung structure interchangeably. And I think we just need to remember again that we have to think about airways and lung parenchyma as two different structures. And we measure them in terms of two different types of function. So for those of you not aware of it, we won't go through methodologies, but airways are most often assessed with forced expiratory flows, or commonly called spirometry. Lung parenchyma, gas exchange in older children and adults, classically, diffusion capacities are the way. And again, we have to remember that the purpose of the lung primary is gas exchange, and the conducting airways are what needs to get the air from the ambient condition for the gas exchange. Of importance, which other people have touched on, is that these things don't develop synchronously. There's a temporal dissociation, and the fact that we all worry about what happens with premature birth, we can't forget the fact that the airways really develop first in terms of the organ development, and we don't really get any potential for gas exchange until, you know, somewhere at the point where we're now seeing the lower limits of survival of these infants. Until you have rudimentary ability for gas exchange, mechanical ventilation, oxygen, any other support won't get us any further. But it's critical to remember that these two things develop in different temporal patterns, not only in fetal life, but postnatally as well. So that if we interfere, we may be interfering by premature birth in each one of them separately, as well as the impact of any injury subsequent to premature birth may impact them differentially. So what I have plotted here is some unpublished data where this is measurements of gas exchange diffusion expressed as a z-score in infants and toddlers that we've measured over the last number of years relative to full-term infants, and also forced expiratory flows, again, now in the same infants. So expressed in terms of, does this show up? I'll try to be ambidextrous. That one works, and see how I go. So in terms of, here's your zero, so better gas exchange up here, worse gas exchange down here. Same thing for airway function, better airway function, a positive z-score, or a negative z-score, lower airway function. And a couple of things to appreciate is if you look at all these infants, and this is a range of gestational ages, most of them fall into this quadrant of having lower than expected gas exchange and lower airway function. Very few of them end up having what you would think is better than average, and some have, you know, better than average gas exchange but lower airway function, and the same thing in the other direction. So there's a lot of heterogeneity. There's differential effects in infants in terms of airways and gas exchange, both one versus the other. The other important thing to realize is this dashed line here is the correlation among all these infants. There is none. So they really are dissociated, and you can't relate dysfunction in the airways or the parenchyma as if you're talking about one disease. There is absolutely no correlation of being abnormal or low in one and being abnormal or low in the other. So if what I just showed you was some data from infants and toddlers in terms of, if here you look at Z-scores in terms of forced flows or airway function and diffusion. And there's data out there for older children and adults which basically say the same type of thing, which is if you follow them out, you can see low airway function, low diffusion at all different age groups. So the question really comes, does impaired airway and parenchymal function early in life improve with lung growth and development? Well, unfortunately, there's very little longitudinal data to really address that question. So I'll try to show you a little bit that's out there, but there's really not much. So when I was in the desert with Lynn Taussig, my mentor, he had just come back working with Simon Godfrey and Lou Landau, following up for Mary Ellen Wohl with the idea of doing forced flows in sedated infants. So these are partial flow volume curves where you squeeze the infant. We won't go into methodology, but this is forced flow. If you use flow as an index or indirect index of airway size, this is normal infants, which actually were kids that then went into the Tucson respiratory study, which is now 30-something years. That's when this was done. And these were infants with BPD, outpatients who were not on oxygen at the time, clinically stable. And it was very interesting at that time where we could show that almost all of them as outpatients had low airway function. What's interesting, as you expect, is they, as a whole, increase with body length or age. So their airways are getting bigger. All pediatric pulmonologists know they clinically get better as they grow. Somatic growth is great. But in general, although there's variability, there was no evidence of any catch-up growth. So they really just kind of paralleled. If anything, you might say they got a little worse, but they statistically no different, really. So there was no evidence that their airways got better over the year. Now, these were infants with a clinical diagnosis of BPD. Subsequent to that, and better methodology, forced flows with the raised volume technique, which is more like spirometry that we do in cooperative older children, where, again, this is data from colleagues in Brazil with Marcus Jones, where he looked at late preterm infants as infants and toddlers, again, outpatients, sedated, raised volume. And these were full-term controls, as you expect, over a year. This was in the first year of life. This was 1 year follow-up. As you expect, the flows, as like airway caliber size, should get bigger. But what happened, these were late preterm infants who had minimal oxygen, less than 24 hours, not even on the ventilator. One can see clearly they're lower, and they parallel. No suggestion that they're doing anything in terms of their airway size, that they're catching up. Gets back to the point earlier today that Alan Jobe mentioned, again, this is compared to full-term control infants, but being born premature in itself is not normal. So what else can you look at in terms of airway follow-up? Well, very recently, this group reported follow-up of 8-year-olds where, again, airway function, spirometry, forced expiratory volume in 1 second, an indirect measure of airway caliber. All three groups, the mild, moderate, and severe BPD, all less than 100% predicted, not surprising. But look, over 4 years, no change. They stay the same. So here we are again with a good suggestion that airway function doesn't look like it catches up. So there we are is what we know about airway function. Born premature, doesn't look like you get better with time. You get a bigger airway with time, so the absolute size is growing, somatic growth is good, and all pediatricians know that. However, there's actually no longitudinal data on pulmonary diffusion following premature birth. So do we know, can you actually catch up in terms of lung parenchyma? We've heard in terms of x-rays getting better, CTs getting better, animal models getting better, but there's actually no data clinically, physiologically measured. So let's ask the question, can lung parenchyma exhibit accelerated growth and development? What data is out there to suggest it actually happens and that maybe it actually is happening in premature kids? Well, John McBride, a pediatric pulmonologist, was interested, and one of the earliest studies was looking at infants who had their congenital lobar emphysema resected as an infant. And when he followed them up when they were older children, their total lung capacity was actually normal. He looked at actually some gas exchange in terms of ventilation, not in diffusion, but they also distributed gas normally in the entire lung. But their spirometry, or their measurement of airway caliber, was still markedly decreased, suggesting at least that the lung volume, parenchyma, could go through compensatory growth relative to the airways, but we don't really have longitudinal data to say what each one of them potentially did separately. Back in the 70s, again, people were very interested in lung growth, and Brody went to high altitude, and these are plots of volume versus transpulmonary pressure. And what he did was measured adults who were highlanders living at high altitude and compared them to adults at low altitude he called lowlanders. So here's TLC, and you can see the high altitude people clearly had bigger volumes. But if you normalize their pressure volume curve relative to the bigger size, they essentially are the same, suggesting that the elastic properties of the lung are the same, giving you at least some idea that the parenchyma probably grew normally. They weren't probably emphysematous lungs, so that they had bigger lungs that maybe grew normally. If you looked at their flow volume curves, and again, in olden days, they used to do, here's TLC, you're blowing out from high lung volume to low lung volume. Here's flow versus volume. Here's your lowlanders, or sea level. Here's your highlanders. So at the same relative percent vital capacity, they had lower flows, suggesting they had smaller airways. Well, the question still is, did they really have smaller airways, or just smaller airways relative to their bigger lungs? So that hadn't previously been addressed. So I had a fellow from northern part of Argentina where he was able to get CT scans of adults living at 6,000 feet. And with the CT scans, now you could get some structural assessment of both the lung parenchyma and the airways. And when he looked at the airways, and we analyzed them by reconstruction of the airway tree, and you could then match them for the same anatomical location of the airways, we could see that for the segmental bronchi and the subsegmental bronchi going out to the periphery, the sea level and the altitude had identical sized airways. So it was suggestive that the lung parenchyma could grow, but the hypoxic environment didn't do anything for the airways. They were identical size, and that stimulus didn't do anything. So we then also looked at the parenchymal tissue, and as you can see here, this is the low altitude and the high altitude, and this is only at 6,000 feet, not much higher than Denver. And here you get a bigger total lung volume by CT. The air volume is higher. The tissue volume is higher. But if you do the lung tissue density, which is how much tissue to air, they're no different at all, which would suggest that here's your low altitude, here's your high altitude. To have the same density, tissue density to air, you basically have the same size alveoli, but you have more of them, creating you more volume. So this would at least suggest that this hypoxic stimulus started early in life, whether fetal, postnatal, stimulating lung growth and stimulating alveolarization to give you those bigger lungs at a high altitude. We also then got Conrad, who set up to measure FRC, functional residual capacity, in infants at high altitude in the Andes, and this is now at 10,000 feet, the high altitude versus low altitude. And we could see that, as one would have expected, if the stimulus really happened early in life from hypoxia, the infant should already have bigger lung volumes. Whether it happened in utero or postnatal, can't answer that at this point, but the lungs are already bigger as infants. So other ways potentially to stimulate lung growth. This is actually a model that John McBride, who was in a slide much earlier about emphysema, developed in ferrets. I've used it in rabbits, so that's why this slide, but actually John McBride first described it of applying CPAP to ferrets. He chose ferrets because they have long necks, easier to get a trach in. So you get the animals trached, have them mobile in the cage, but now you can apply CPAP, either keep the pressure at 0 airway distending pressure, and this is just, again, to orientate people what you're doing. Here's lung volume versus airway pressure. If you have a 0 airway pressure, ambient, open trach, here's your tidal breathing. And then if you put the animals at a CPAP of 6 centimeters of water, you increase their lung volume and they breathe at a higher lung volume. And with these ferrets, John was able to show that after 1 week, he had bigger total lung capacities in these animals. And it actually then went for 2 weeks, they got a little bit bigger, but within a week of chronic CPAP, you could have a bigger TLC. He also did pressure volume curves to show that the elastic properties of the lung were the same. So again, like the high altitude, they weren't emphysematous lungs. They were normal lungs in terms of their elastic properties. So then the question is there any indication coming out of our NICUs that CPAP may be advantageous to stretch the lungs? So we look back at some of the data that we collected over a number of years of measuring alveolar volume DLCO on infants, not in the NICU, but as infants under sedation as outpatients. And here's a group of full-term controls, and we compared them to preterm infants without BPD. They were clearly younger, as you'd expect. We assessed them at comparable corrected ages. They were comparable body lengths and comparable gender when we made the measurements as outpatients. And we were asking the question, if you looked at alveolar volumes, were any of these related to their alveolar volume? Their body length was highly correlated, which is you'd expect. The bigger the baby, the bigger their alveolar volume, or bigger anything somatic. Gestational age was not associated with a bigger, gestational age at birth was not associated with their alveolar volume after you adjusted for their length at the time of testing. Exposure, just a yes or no to supplemental oxygen, not quantitative, not how high, not how long, had no relation. Whether they were on mechanical ventilation, yes or no, not how long, not how peak pressures were. CPAP, simple yes or no, was correlated with alveolar volume. If they were treated with CPAP during their NICU stay, they had a bigger alveolar volume than if they were never treated with CPAP. So that was alveolar volume, and we actually had diffusion measurements in these infants as well. And if we look through the same variables, as you'd expect, the bigger your somatic size, your body length, the bigger your diffusion. None of these were associated with their diffusion capacity. If they had ever been on CPAP, they had a higher diffusion than compared to if they were never on CPAP. So there was now some suggestion moving from John McBride showing that apply CPAP, maybe you are stimulating, but this is cross-sectional data. This is not longitudinal data at all, and it's uncontrolled intervention. So here we now go with Cindy McAvoy in Portland, who we collaborate with, So she was asking the question, if you discontinued standard CPAP, this was presented in abstract form, I think at PAS this past year, but if you discontinued standard CPAP by their clinical criteria, or they were randomized to either stop it or prolong it for another 2 weeks, would that have an impact on their lung volume 2 weeks and at discharge? So here they were randomized, no difference in terms of gestational age, birth weight, percent male, antenatal steroids. And here we find that randomization, their FRC, lung volume at functional residual capacity, was no different. 2 weeks later, it's higher in the CPAP prolonged group, and it looked like it sustained it as they were measured at time of discharge. So now some, again, non-cross-sectional data, whether it's functional, whether the diffusion is better, unclear. Bigger doesn't always mean better, but the intervention of prolonging CPAP in a randomized manner seemed to give bigger lungs in premature infants. So what are some questions that I think are important for us still to address? Well, do the airways and the lung parenchyma differentially contribute to the short and long-term respiratory morbidity following premature birth? They're two separate compartments, and we really have no data as to if either, both combined, are contributors to their respiratory morbidity over the subsequent year or two of life. As pediatric pulmonologists, we frequently know airway disease is important, but they often get in the hospital and need more oxygen. What's the underlying pathophysiology that makes those go in the hospital, those not needed to be in the hospital? Probably an important question. Do the airways and lung parenchyma undergo differing rates of catch-up growth following premature birth? Suggested data I've showed you is the airways may not do it, but the parenchyma might, but we really don't know that yet. That may be important for us to answer questions in terms of therapeutic strategies. Can therapeutic strategies be targeted to minimize lung injury to the airways versus the lung parenchyma? That's kind of a preventive issue. The other side of the coin is you already have disease. We haven't been able to stop BPD yet, or lung disease. So can therapeutic strategies be targeted to enhance catch-up growth of the airways versus the lung parenchyma? That's a whole different question than just trying to prevent it. We haven't been that successful. It's like saying I'm going to prevent premature birth, and then we wouldn't have a problem. It hasn't happened. So maybe we need other targeted strategies of, can we make the airways better? Is there a way to do that? So with that, I'll stop and answer any questions. Thank you.